Today I will talk about corticosteroids in uveitis. This talk will be mostly like a review of basic and practical points of this subject. Since their discovery in the 1950s, corticosteroids have been the mainstay of treatment of ocular inflammatory and immune-mediated disease. And despite advances and varieties of anti-inflammatory and immune-modifying agents, corticosteroids remain the first-line treatment option for many ocular and non-ocular inflammatory and immune-related disorders. And this popularity of steroids is mainly because they are very strong medication, they are very efficient and rapid in action, they are cheap, they are non-selective with broad-spectrum anti-inflammatory and immune-mediating action, and they have a good short-term safety profile. However, the medium and long-term use is associated with a lot of serious ocular and systemic adverse effects, which mandates judicious and careful use and good knowledge of the guidelines and precautions of their use. I will start with some basics about the steroid. A steroid is a biologically active organic compound with 4 rings arranged in a specific molecular configuration. And to these 4 rings attach side chain, and according to this side chain, different types of steroids are produced. The steroids could be natural or synthetic. Natural, like the adrenal cortical hormones, like sex hormones, like bile acids, cholesterol. Synthetic, like many synthetic anti-inflammatory agents, or anabolic growth-stimulating agents, or oral contraceptives. This is the basic steroid core. It is 17 carbon atom arranged in 4 rings, and cholesterol, which is the prototypic animal steroid, is formed from this main core, and from cholesterol a cascade of reactions and events occur in the body with the final production of different steroids. This is the cascade of reactions that occur in our body. It starts from cholesterol by the action of the adrenocorticotropic hormone, and it will end with the formation of different steroids in the body. As we said, steroids vary from one another in the nature of the attached side group and the position of this group and configuration of the steroid nucleus. Small modification in these structures can produce different types of steroid with remarkable differences in their biologic activities. Other determinants of the biologic action of steroids is like the route of administration, concentration of the medication, frequency of application, duration of treatment, the potency of penetration of ocular tissues. Also, age of patient can play a role, and also some genetic predisposition is claimed to play a role. The mechanism of action of steroids, we have short-acting that start immediately within minutes to hours, and it is based on non-genomic mechanism, while the main long-acting effect is through genomic mechanism. The non-genomic mechanism, it is rapid, it starts within like minutes. It is mediated through interaction between the steroids and some membrane-bound receptors, and this complex can cause like mechanical modification of some inflammatory factors and enzymes. While the genomic effect, it is based on the adhesion or attachment of steroid to specific receptors in the cytoplasm, and this complex will go to the nucleus attached to the DNA and cause like positive or negative effects on the DNA. The positive effects, it can induce the synthesis of anti-inflammatory proteins, while the negative effect, it blocks the transcription of some inflammatory genes. This is also some illustration, and this is the glucocorticoids, which are the main anti-inflammatory. As we know, it has systemic effects and local ocular effects. We will go through them. What's the most important for us is the anti-inflammatory and the immune suppressive effect of steroids. The anti-inflammatory is mainly through action on neutrophils. It will inhibit neutrophil migration and also adhesion to vascular endothelium, and then also inhibition of the inflammatory cascade. While the immunosuppressive effect is mainly through action on the mononuclear phagocytes and on lymphocytes. This will lead to decreased chemosis and chemotaxis, and decreased clearance of antibody-coated particles. Also in lymphocytes, this will inhibit T lymphocyte activation, also inhibit proliferation and lymphokine production. Actually, steroids mainly affect the cell-mediated immunity and mainly T-cell lymphocyte. But in high doses, it can also affect antibodies production by B cells. Also, other effects like metabolic effects. It can induce gluconeogenesis, which raise blood glucose level. Also, it can cause lipogenesis, which can lead to fat distribution in the body. Some catabolic effects that lead to decreased muscle mass, or fat wasting, or osteoporosis, or inhibit growth in children. Also, some CNS effects that can lead to some psychiatric manifestations, and mineralocortical effects that lead to water and sodium retention. GI effect can cause gastric ulcer. The complication, a big list of systemic and ocular complications. We might go through some of them during the talk. Now, to the treatment, some considerations that should be taken before starting treatment. We should first, as we all know that whether this uveitis is infectious or non-infectious. We should know also if there is any posterior segment involvement, because this will decide the type of steroid that will be used. Also, if there is association with the systemic disease, any ocular comorbidities like keratitis, glaucoma, cataract, risk of central serous retinopathy, or history of CSR. Also, the vision potential is important in decision of using type of steroids. And always medical evaluation is a must before starting systemic steroids, including psychiatric and drug history. And when doing investigation for uveitis, it's better to do lab tests, especially the immune assays, before starting the treatment, because this might affect the result, as we will see. The routes of administration of steroids is different. It can be given systematically or topically, or via injection, like in the orbital floor, or like in the intravitreal or suprachoroidal injections. I will start with the systemic corticosteroids. Some indication of systemic corticosteroids are chronic bilateral disease beyond the anterior segment, non-infectious of course, and also the anterior uveitis resistant to local therapy, especially in children. Also uveitis associated with systemic disease that need systemic treatment, even if they are manifested by anterior segment manifestation. They should be treated systematically, like VKH, Behçet, sympathetic ophthalmia, among others. And also systemic corticosteroid can be used as a bridge therapy like when we are using other immunomodulating therapy or biologic. Some they advocate or recommend starting with either IV methylprednisolone or systemic as a bridge until the effect of these medication starts. And also it can be used for bilateral macular edema, or if periocular or intraocular corticosteroids are contraindicated. Some guidelines, we took or we mentioned some of them before. We should rule out infection or malignancy as a cause of uveitis. Medical clearance is a must before starting systemic treatment. And as a rule, you should hit hard and hit fast. So the induction should be with full dose corticosteroid to control inflammation. And in chronic uveitis, we should maintain the patient on the lowest possible steroid dose, plus the starting immunosuppressant treatment. And also, as we said, we should encourage early shift to immunosuppression medications in children. Also, close monitoring of side effects and regular medical follow-up and referral is a must. As we mentioned, better to do immunological assays before starting systemic treatment, if possible, of course, because the results might be affected, like PBD test might be negative, or ANA or angiotensin converting enzymes. However, the systemic steroid will not interfere with quantiferon testing. We are giving systemic steroids in two phases. The induction phase, which is the initial phase to treat the active inflammation, and we are using the maximum dose. It is applicable to all cases of inflammation, and we start it as quickly as possible. While the suppression phase, it is applicable in the chronic inflammatory disease that needs long-term treatment. And the long-term suppressive therapy is the key to long-term success and good outcome in chronic uveitis. We are using prednisolone. We start usually with the dose of 1 milligram per kg daily until inflammation improves. The maximum dose in the literature, it is recommended not to exceed 80 milligram per day. And we start tapering when there is response, but not less than 1 to 2 weeks. Also, it is, if indicated, it is better to start immunomodulating agent from the beginning, not waiting as some doctors do. Also, maintenance, the aim of maintenance dose should be equal or less than 10 milligram per day. Supplements are very important, daily calcium and vitamin D. And we should monitor at baseline and during the treatment course some signs or some vital signs like blood pressure and electrolytes, fasting glucose level, CBC, and weight. It is recommended to be checked weekly for the first 2 weeks and then every 3 months. Also, bone density and lipid profile within the first 3 months and annually thereafter. Diet, it is better to avoid salty and high sugar food, and don't forget to prescribe proton pump inhibitors, especially for those who are prone to develop peptic ulcer. As we said, the maximum oral dose in the literature is between 60 and 80 milligram per day, and this is because some literature in the rheumatology found that doses above 60 milligram per day are associated with an increased risk of ischemic necrosis of bone, and the recommendation that it should be avoided the high dose. But if the patient needs induction dose more than 80 milligram, like an obese patient, we can bypass this precaution by adding like adjunctive pulse IV treatment, or we can use periocular injection as adjunctive treatment in cases of unilateral uveitis, or we can use the maximum dose of the steroid-sparing agents. The maintenance dose, as we said, it should be the target between 10 and, some also literature say it should be less than 7.5 milligram per day. Why? Because in some literature that they found that daily oral prednisolone dose in excess of 7.5 milligram per day is associated with a greater than twofold increase in the risk of cardiovascular events over very long term, very long, like more than 10 years in the risk. And if the patient reaching the very low dose and we are about to DC the medication, if he cannot tolerate DC, if he develop any side effects, so we should test the hypothalamus pituitary adrenal axis because it might be suppressed, and in such case they will need maintenance dose of this dose or even lesser than this. The tapering schedule for steroids, if the dose is over 40 milligram, we are usually tapering by 10 milligram Q10 to 2 weeks actually in our practice. And if the dose between 40 to 20, we taper by 5 milligram every also 10 days to 2 weeks. If the dose between 20 and 10, the recommendation is to taper by 2.5 milligram every 1 to 2 weeks. And if the dose is 10 milligram or less, we taper by 2.5 milligram every 2 to 4 weeks, or even slower than this. Short-term therapy up to 3 weeks, even if at high dose, can simply be stopped without tapering because the hypothalamic pituitary adrenal axis suppression will not persist and it is unlikely to have any clinical consequences. Now, immunosuppression, when to add immunosuppression? Actually, as Prof just mentioned, systemic corticosteroid used as a monotherapy are usually insufficient to achieve control of intraocular inflammation at the therapeutic or the threshold dose. So generally, steroid-sparing immunosuppression drugs are needed if the treatment with steroid is expected to exceed 3 months. And also other recommendation to add immunosuppression if there is inadequate response after 2 to 4 weeks of high-dose treatment, or if the patient cannot be maintained on maintenance dose less than 10 milligram by 3 months, or in some ocular disease that are known to have poor prognosis with corticosteroids alone, like Behçet, BKH, or juvenile idiopathic arthritis. Also, if the patient is unable to take corticosteroids, and also in childhood chronic uveitis. In all these conditions, we should also add immunosuppressive treatment. What about the management of flare-up that can occur during the treatment? If the flare-up is mild, we can just double the prednisolone dose, or we can increase the dose of steroid-sparing agent like Celsep or cyclosporin, or we can give pulse IV treatment for 3 days or 5 days. But if the flare is moderate to severe, we might need to repeat the induction cycle. And some report they do not recommend more than 1 time per year to repeat the induction cycle. And we can consider biologic if the patient are developing flares, severe flares more than once per year. About systemic steroid in children, short-term oral steroids are acceptable, but long-term there is a risk of growth retardation, although low doses on the long term can be safe with close monitoring. And we should start immunosuppression or steroid-sparing agent early. And of course, there should be close pediatric and rheumatology follow-ups. This is a paper published It is done in King Abdulaziz University Hospital, published by Dr. Blushi and Prof. Abdulslam. They reviewed 38 children with VKH, and 5 of them had insulin-dependent diabetes mellitus. All children received systemic corticosteroid and immunomodulating therapy, and the maintenance steroid dose was between 5 and 10 milligrams per day. The mean follow-up period was about 5 years, and over this period there was no reported serious treatment-related complications. So with close monitoring, long-term oral steroids is quite safe in children. But of course we should add immunomodulating agents. Now, so there are some ways to minimize the side effects of steroids, systemic steroids. We should minimize the effective dose, and it's better to early use of steroid-sparing agent, maintain the patient or aim for the maintenance dose to be equal or less than 7.5 milligram. Limit reinduction in case of flare-up to once per year. If there is flare-up more than once per year, we should consider adding biologics. If recurrent flare-up, we can either, as we said, modify the immunosuppressive dose, use pulse steroid, or use local steroid, or consider biologic. And also vitamin D and calcium supplement can prevent many side effects, especially the osteoporosis. We should monitor blood pressure, glucose, weight, and monitor electrolytes and bone density, and ensure regular follow-up with medical. This is also another paper, and also the conclude that we should limit the use of high-dose corticosteroid to once per year if there is flare-up. If there is flare-up more than once per year, it is better to look for another treatment modality. What about the use of pulse IV methylprednisolone? It offers immediate control of vision-threatening complications, and also it is very helpful in painful disease like necrotizing scleritis. It can be used as bridging therapy till the action of other treatments starts. And if oral steroid fail to achieve quiescence, or if the induction dose more than 80 milligrams per day, or it can be used preoperative in high-risk patients. Also, we should not forget the drug interaction that can occur between steroids and other medication the patient uses. There are some medication that can increase the concentration of steroid, especially cyclosporin A, and also some drugs that decrease the concentration of steroids. Also rifampicin. This is important when treating TB uveitis. What about the use of corticosteroid in infectious uveitis? Generally, corticosteroids are contraindicated in infectious uveitis without coverage of antimicrobial drugs. But many infectious uveitis are associated with an inflammatory component that can be as destructive to ocular tissue as the infection itself. So corticosteroids may be a good additional anti-inflammatory treatment for infectious uveitis when given in moderation and, of course, after coverage with antimicrobial agents. Usually, if we need steroids, we are using topical or systemic, but not intravitreal. Intravitreal should be avoided. The exception we will mention is TB uveitis. Usually, we start the systemic corticosteroid 24 to 48 hours of starting the antimicrobial treatment. As we said, the exception in TB uveitis because there are many literature that showed improvement of uveitis, of TB uveitis when adding corticosteroids, whether injection or systemic, in cases of severe vitritis or cystoid macular edema or worsening of paradoxical worsening after starting the anti-TB treatment. What about corticosteroid in pregnancy? It is safe to be used in pregnancy, but there are some reports about increased risk of preterm birth or low birth weight or preeclampsia or gestational diabetes mellitus, but the available clinical data and literature do not support this association. Most clinical reports confirm the safety of steroid during pregnancy. The only concern is when we are giving breastfeeding women a high dose exceeding 40 milligram per day. The infant should be monitored for possible of adrenal suppression, because steroid can be secreted in milk in very low amount. Also, another study done in our hospital, King Abdulaziz University Hospital, about the outcome of initial onset acute uveitis associated with the VKH that occurred during pregnancy. It reviewed the file of 10 pregnant ladies with initial onset acute VKH. All of them, they were treated with combined systemic corticosteroids and cyclosporine in the initial acute uveitis associated with VKH. And the conclusion was the treatment with the systemic steroids and cyclosporine was safe and effective. This is about the systemic corticosteroids. I might also talk about local steroids. I don't think we can finish the lecture, but I will mention some points about the locally injected corticosteroids. We have many preparations of locally injected corticosteroid that can be injected either periocular or subtenon or intravitreal or intracameral or recently suprachoroidal. The advantage of periocular or intravitreal corticosteroids, they provide adequate local control of inflammatory problem. They avoid the side effects of systemic drugs. They are simple procedure and no need for special equipment. They are office-based procedures and they can be repeated as needed. What are the indications? Usually we are giving periocular or injected corticosteroid for the uveitic macular edema or for resistant unilateral anterior uveitis that is not responding to topical treatment, or in non-infectious intermediate or posterior uveitis. In cases if this intermediate or posterior uveitis is unilateral with no systemic association, especially in pseudophakic patients, or we can use it as adjunct or bridge therapy in early phase of systemic treatment, or adjunct therapy in unilateral flare-up while the patient is on systemic treatment. And we can use it temporarily when systemic treatment cannot be used safely, like in uncontrolled diabetes or pregnancy. If the pregnant lady cannot tolerate high dose of systemic steroid, we can give her local or injectable corticosteroids. And when the periocular or intravitreal corticosteroids are not appropriate, of course in infectious uveitis, with the exception of TB uveitis and possibly toxocariasis, if there is ocular tissue like conjunctivitis or blepharitis, if uveitis associated with systemic disease, not contraindicated, but contraindicated to use it as monotherapy. We can add it to systemic therapy, of course. And if there is diagnostic uncertainty because this might be infectious or masquerade uveitis, if the media is not clear, it is also better to wait. And I don't know this, I just found, I don't know what's the rationale. It is also contraindicated in exudative retinal detachment. Some talk about, actually we are not doing this posterior subtenon or orbital floor, so we can skip it. I will talk about intravitreal corticosteroids. The earliest injectable intravitreal corticosteroid is triamcinolone acetonide. And there is no consensus for intravitreal triamcinolone dosing in uveitis. The published studies use a range of 2 to 8 milligram per injection, and some studies showed that 4 milligram intravitreal triamcinolone is effective for cystoid macular edema and visual acuity improvement. The effective treatment duration is between 3 to 5 months. Actually, it is in our practice not more than 3 months. The problem with the Kenalog or triamcinolone acetonide, actually the usual injected triamcinolone is Kenalog, but many reports they found high percentage of sterile endophthalmitis when using the brand Kenalog. The reported rate is between 0.2 to 6.7% of injections. So there is now a preservative-free TriSense triamcinolone acetonide, and it is FDA approved to be used locally in cases of sympathetic ophthalmia, temporal arteritis, uveitis, and also in visualization during vitrectomy. It is also used off-label for other indications like uveitic macular edema. And the theoretical advantage over Kenalog that this brand is preservative-free. Also, it has less particle size and less precipitation of drug crystal that occur frequently with Kenalog. The next intravitreal corticosteroid is Ozordex, and it is sustained release biodegradable 0.7 milligram dexamethasone implant. Compared to intravitreal triamcinolone, it offers the advantage of a gradual and sustained release of the drug to the posterior segment, resulting in reduced rate of relapses and re-injections. And it has approximately 12 times higher anti-inflammatory potency than triamcinolone acetonide, and also it has higher intravitreal concentration. This is the trial that led to approval of the Ozordex, and it showed resolution of vitritis in most of the eyes, and about 40 to 70% of eyes. They need repeated injection in a mean of 6 months, but actually also in our practice, the duration is not more than 3 months. This is a famous point trial. It compared periocular triamcinolone versus intravitreal triamcinolone versus intravitreal Ozordex for the treatment of uveitic macular edema. And it showed that both intravitreal triamcinolone and intravitreal dexamethasone implant were superior to periocular triamcinolone for the treatment of uveitic macular edema. No difference within the intravitreal group, so intravitreal triamcinolone is equally effective like Ozordex. And there is modestly greater rate of mild intraocular pressure elevation for the intravitreal triamcinolone and dexamethasone implant. Now to the intravitreal fluocinolone acetonide. We have 3 commercial implants. We have Elovin and Utic, which are injectable implants, and we have Retisert, which is surgically fixated implant. Despite the short half-life of fluocinolone acetonide, the non-biodegradable implant releases the steroid at a stable rate up to 3 years. The first FDA-approved injectable implant was Retisert, and it is designed to release fluocinolone acetonide at a nominal initial rate of 0.6 microgram per day decreasing to 0.3 microgram per day over approximately 30 months. And this is the trial that, no, this is another trial, MUST trial. It compared systemic treatment for non-infectious posterior uveitis to treatment with injected or with Retisert. And they found that both implant and systemic group showed improvement in intraocular inflammation and best corrected visual acuity, with no statistically significant difference between both groups. And on 24 months, the control of inflammation was more frequent in the implant-treated group than in the systemically treated group. But the long-term extension of this study found that after 4 years, there is higher risk of edema recurrence in the implant group comparing to the systemic treated group. And the visual acuity outcome is better in the systemic treatment group after 4 years. So the conclusion was there is a need to repeat Retisert implant in a timely fashion, like after or Q3 to 4 years. Because of the surgical complication of Retisert, like hypotony or high intraocular pressure or scleral thinning or endophthalmitis or separation of the implant from the strut, there was produced another sustained release fluorescein implant, which are Elovin and Utic. They are injectable drugs that do not need surgical approach. They are injected intravitreally with a 25 gauge needle in an office-based setting. And also they both are designed to release fluocinolone acetonide over a 3 years period. This is the actually the FDA approved injectable fluocinolone acetonide is Utic. Elovin is FDA approved for diabetic macular edema, but not yet for uveitic macular edema. So this study is about Utic, and it showed that the Utic is a safe and effective treatment for chronic and recurrent non-infectious posterior uveitis, being associated with a substantially lower recurrence rate and longer recurrence-free time compared to the standard of care. Now, what to use? Dexamethasone Ozordex or Elovin, let's say, because we are using Elovin. Actually, there is lack of comparative trials between those two medications. So it is difficult to draw conclusion about which implant is better in terms of efficacy and safety in the long-term treatment of non-infectious uveitis. And another important point that these implants have been licensed with different indications. The Retisert was approved for the prevention of recurrence of uveitis, while the Ozordex was approved to treat active uveitis. Now, the newly approved injectable steroid is suprachoroidal triamcinolone acetonide, Zyper, and it is FDA approved recently for the use of for use in treatment of macular edema associated with uveitis. The advantage of suprachoroidal route is it facilitates targeted delivery of corticosteroids versus intravitreal injection, and this reduces exposure to non-target regions of the eye. So theoretically, the risk of other complications like cataract and glaucoma should be lower with this route of administration. This is the treatment, the suprachoroidal. It is delivered via a microneedle in the suprachoroidal space at the same site, 3.5 millimeter from the limbus. And these are the trials that lead to approval of this medication. This is the PH3. There is a study that compares suprachoroidal triamcinolone with and without systemic corticosteroids, and the conclusion that the suprachoroidal triamcinolone is effective regardless of using systemic therapy or not. So this was about the locally administered corticosteroids. I don't know if there is time we can talk about topical, or I think it's better to stop here. Okay, thank you very much.